well. So let's get stuck in. So the outcomes for tonight, we're going to be recapping the pillar and 4 postures related to the ground, and then principles of force production and absorption as we talk about how that force is navigated throughout the lower quarter zones of control. So we move in and let's do our quick recap here. So we've got the pillar, based on what we talked about last week, defined by the 4 key structures. We've got our shoulder girdle, our spinal column, our rib cage, and our pelvic girdle, and they create kind of like a rectangle, or if you think about a pillar that holds up a roof, they create this pillar, and that pillar helps us navigate force coming in either from the legs or from the arms, and it helps us transmit or redirect that force back down into the floor again. We go on to posture. So we're looking at the way that we define posture in terms of this, I guess this mentorship, is that it's defined simply as a position within a pattern. So the way that we navigate from position to position, we can define that simply as poise. So a movement pattern, depending on how clean it is, we can determine that as either poiseful or less poiseful. But position is just simply a posture that's a snapshot in time of that pattern. And then the motor control that comes with that, the cleanliness of that pattern, can be defined as poise or clean motor control. And then we talked about how there aren't typically any good or bad postures, just more ideal and less ideal task-specific positions within a functional pattern that we discussed in the last webinar. Okay, and then we move into our positions. So position 1, as this recap here, is supine. So we're on our back, and this is a supported position, a fully supported position for the pillar. So there is no gravity, there's no load going through the spine or the adjacent structures. This lady here is just laying on her back, and no load is passing through her pillar. So this is the ideal position for bringing attention to tension or pain within the system. And we find a position of ease in this supported position to start building a platform of movement on. Position 2 is quadruped or suspended. And this is where we take our arms and our legs and we now suspend the pillar horizontal to the ground. So we still don't have any axial load, some compressional load going through that spine. It's a little bit of shear force, but we're being supported in 4 key positions here. So this suspended posture, this introduces some partial weight bearing through the spine via shoulder girdle and pelvic girdle, which are the 2 top and bottom gateways to the pillar. Also, this is our first position where we can start to introduce a anti-flexion and anti-extension moment within a pattern and introduce that with breathing to create higher tier function away from our supported or supine position. Position 3A is our half kneeling or our stacked position. Stacked because this is the first time we introduce compressive or axial load through the spine. So we are stacking the spine and the pillar over the hips, and we are trying to balance the center of mass across 2 hips, one on the floor and the other posted out in front. And then position 3B is our tall kneeling. So we are still stacked, but in this position, we have a much narrower base of support than we do here. Here is a little bit broader than here. We're still introducing the same spinal or compressional axial loading through the spine and the pelvis. And then position 4 is our standing position. And this is typically where we get to produce most of our force. And we are also at our most maneuverable due to these little bad boys at the bottom of our legs called our feet. Okay, so we're going to move into our lower limb control zones. There's 2, but there's 3 parts that make these up. So we've got our 3 parts here, the foot, the knee, and the hip. And as you'll see, as we move into each of these complexes, they work in sync with each other. They synergize quite well together. But the caveat there is that when one area starts to misbehave, that can cause a chain reaction of misbehavior up or down the chain based on where that dysfunction may occur or that misbehavior may occur. So if we move into our ankle complex, we're going to be looking at the way that we produce force, transmit force, or absorb force from the ground through the foot. So this first sentence here, when we're discussing force production, transmission, or absorption, our first and last stop is the foot. Remember that force is produced from the ground via gravity, So gravity is interpreted by our nervous system as an external load that we push against to stand up. And that standing up is creating force, and that force is created via the ground through our feet. So foot function is quite important. I hold a lot of stock in foot function, and we're going to see why in a couple more slides. But just understand that the way that we produce force, regardless of if we're lifting weight, or if we're running, or if we're tackling someone or being tackled, or if we're just sitting on the couch and standing up, we're producing that through the floor, and every sort of micronewton of force that we produce into the floor must be absorbed and recognized within the nervous system so that we can navigate the perturbations that come with that, particularly if we're using our feet, which are small, narrower bases of support. So forces produced through our contact with the ground and healthy inputs received from the ankle complex can and will play a significant part in your ability to access patterns both in an open and a closed chain. So, I mean, you guys should understand this already, but just in case you don't and you need a recap, an open chain means that the distal segment is not fixed, which would be here. And a closed chain, just mute your mic, whoever just came in. And then a closed chain would be a distal segment that is fixed. So in this case, it would be the foot on the ground. Then we move into the complex that it's made up of. So this complex is made up of several joints, which we'll explore in the next slide. And while these sections, these joints, they appear to be different, and they all appear to kind of not have a lot of mobility. They don't have a lot of movement associated with them. They work together via movement patterns throughout this whole complex that help to create a really strong foundation and clean pathways for force to travel straight up the leg. Force likes to travel in straight lines, particularly when it's moving in and around the pillar. And then this last one here, remember, so this is just a cheeky note to remember as we move forward. Joints don't work in isolation. We can test them in isolation to see if they've got adequate amounts of range, but they never work in isolation based on the way that our spine is responsible for creating stability, a stable base to produce movement off. So if you were to lay on your back in position 1, a supported position, and just lift your leg, you will feel your pillar, your spine, your pelvis, your shoulder girdle, you'll even feel your arms. They will tension themselves to create some stability for you to lift that leg off. And that's very important to understand. No joints work in isolation because the nervous system doesn't work in isolation. So these joints throughout the foot, they're actually specifically designed, just like all the joints within the kinetic chain, are designed to specifically function as a way of supporting the surrounding soft tissue of the joint that is connected to that joint, and also to the next joints within sequence throughout the entire kinetic chain, all the way from the foot up to the head. Because gravity doesn't just affect one joint, it affects the entire system. Very important to understand and remember. Now we move into the ankle complex, and as you can see, it is quite complex, but in its complexity, we can chop and change a few things to make it a little bit more simple. But let's just dive in. So we've got our ankle complex, and there are many, many different bones. They're all color-coded differently here. There are many different bones working together here to create as much intrinsic stability as they can. So you can see that a lot of these bones, they're long, but we don't have these huge gaps in terms of the bone throughout the foot. There's a lot of tissue that sits in between these bones. And if I was to palpate a foot, I can palpate and get a bit of movement through those bones, but not a whole lot, because the skin and the fascia that wraps the skin is holding that very tight. So this entire complex here is actually designed for a lot of intrinsic stability, which means not a lot of movement. And the reason we don't want a lot of movement is because we need to base the rest of our body's support off a very narrow, in the sagittal plane, very narrow base of support. Now these pieces, even though they don't need a lot of movement, they still need to be able to move relative to one another. Now this movement, this mobility, is not always going to be easy to measure or assess, and that's going to be true for a lot of the bones throughout the rest of the lower body through the control zones. But that movement still exists, and it exists via functional or accessory movement. And we're going to break into some more of that functional and accessory movement thought process as we go. But just understand that even the stiffest bone on each side still needs a little bit of give, because if it doesn't have that give, it hasn't got the ability to absorb force coming into it across the bone. And it's very important that that's what we remember joints do. joints don't just help us move through space, they help us navigate the force that comes across a bone. And these joints here, that's exactly what they do. They help us navigate the force that crosses these bones, because these bones are very important for creating leverage through the toes all the way into this midfoot section here, these tarsals. Let's keep going though. So where were we? The movement. So we've got this movement throughout the foot that we need, and it's important because we need it for anti-movement. If we don't have the ability to have some of that accessory movement in the foot, then we lose the shock absorption, or we lose the anti-movement ability of that foot. So a stiffer foot isn't necessarily better if we don't know how to use that stiffness. Just as a springy, supple foot isn't necessarily better if we don't know how to land soft and absorb force through the foot. So we've got a lot of bones in here, and this can be quite overwhelming, but let's quickly go through them here. So we've got our distal phalanges here, and these are the yellow bad boys. Our middle phalanges here are these green ones, and our proximal phalanges here, and they sit through this, I beg your pardon, sorry. Middle phalanges here are these green ones, and the proximal phalanges here are these teal colored ones. And these are designed to create sectional leverage it's called toeing off, as we move through gait cycles. So as I step this foot into the ground, and then the foot moves past my hips and I'm stepping off onto my next step, these toes, they create this sectional leverage where I'm creating movement, small little movements or small little flexion and extension moments throughout these joints. So I'm not creating a whole lot of tension up through these tarsal bones up in the foot. These tarsal bones here are designed for a little bit of shock absorption, but this is where much of the shock absorption comes from due to the nature of this flexibility through these sectional levers. Then we move into this purple area, which are our metatarsals. And again, these act just as longer sectional levers. So now we're trying to create movement, and a little bit of anti-movement as we move into the stiffer sections of the foot. So we're moving, and now we're creating a little bit of anti-movement. And you can see as these bones get a little denser that we're not going to be getting as much movement out of these sections of the foot. These tarsal bones create the firm bottom plate of the foot that you can roll backwards and forwards within the frontal plane, or within the frontal plane. And underneath here, we've got our ankle bone, which we're going to explore in the next slide, and then our fibula and our tibia that sit on top and attach our foot to our leg. So that's essentially the ankle complex, but we can make it a little less complex and a little bit more simpler for our purposes. So if we move into this ankle complex and make it a little simpler, all we can do is just look at it a little bit more pragmatically. The forefoot houses many of the phalanges, and if we remember, those phalanges, they're just designed for sectional leverage. So the more distal sections move a little bit more to create the space for our anti-flexing or our anti-moving sections to absorb some of that force. So our forefoot does a lot of movement, and it does it in sections. Our midfoot, so that's these more purple bad boys, they're not necessarily designed for a whole lot of movement, but because they're longer, they're designed to resist or absorb a little bit more movement. Then we move into our hind foot, our tarsals. And again, this isn't really designed for a lot of movement. There's going to be slight joint play here for shock absorption, but not a whole lot. And this is where our subtalar joint, or the joint that allows us for inversion or eversion of the foot, exists. And it exists by housing itself just underneath these little bad boys here. This is called your malleolus. So we're looking at a right foot here. This would be the inside of that right foot, or the medial malleolus. And then you've got your lateral malleolus on the other side. And then underneath here, this little purple mass, this is your ankle joint that allows for flexion, or plantar flexion, dorsiflexion within the sagittal plane. And this is completely encased, like a dome, completely encased within this tibia and fibula pairing. And that's called your talocrural joint. And we're about to look at these in terms of what we can expect from movement. So let's just quickly recap, just to make it a little bit less complex. Forefoot encompasses the phalanges, so that's here. And that's designed for a bit of movement. So we need that extension through these toes as we toe off. If we don't have the extension, then we can put a little bit more stress through these sections of the foot, or further up into the knee or the hip. The more proximal we get, the less we have of this sort of, I'm going to say flex, but it's not actually flexing. in terms of anatomical movement, but there is a flex in terms of allowing for that movement to occur. Now, it's not easy to measure these, but we should still try our best. If I was going to suggest measuring something, I would pick the big toe and ensure that we're getting 40 to 50 degrees of extension in our big toe. So that's lifting the toe off the ground in an open chain, which is to say that we're not assessing it with the toe fixed to the ground as we move the foot. So we're wanting to see if we can get 40 to 50 degrees of open chain big toe extension. As restrictions start to ease with Corona, I'll be able to run you guys through these assessments either in the shed in Frankston or up at Ballarat with Radders. So don't fret, I can run you guys through these in future, but just understand that these ranges exist so that we can take stress off other structures above or below. Now, the big toe is the most distal segment of the foot and the lower limb. If we don't have it, then we're creating more stress further up. Remember, if this doesn't extend, then these pieces that become less movable the closer we get to the midfoot, they take on more stress. And so too does the knee above. Now we've got plantar flexion, which is we stand and we point our toes and we push into a calf raise. Now, when we go into plantar flexion, we're actually going into big toe closed chain extension. And if we don't have big toe extension in the open chain, then we're going to have a hard time assessing plantar flexion in a closed chain environment. I recommend measuring plantar flexion in a closed chain if you're confident that you haven't missed anything with big toe, because there's a great way to assess motor control there as well. Now, plantar flexion, we're looking for 40 to 50 degrees. Is it easy to measure? Not necessarily, but if we know where 0 is, which is the floor, and we know where 90 degrees is, which is just a right angle, all you have to do is watch where the midfoot, so we're starting here, the midfoot, this is the part that will come off the ground. These parts won't. So there's the ball of your foot. The midfoot will come off the ground and create a lever. We're watching for where this lever and this malleolus, if we draw a straight line, we just want to know where that straight line finishes. Does it get past 45? If it does, let's call it between 40 and 50. Does it not get close enough to 45? If it doesn't and you're not sure, then just mark it down and say, look, we're probably a little short on plantar flexion. Go and check big toe extension. We might be missing big toe extension. Dorsiflexion. So we need 20 degrees in an open chain and 40 degrees in a closed chain. With dorsiflexion, so 20 degrees in your open chain, due to the natural ropey sort of elastic properties of the calcaneal tendon, the Achilles tendon, it can be really challenging to measure dorsiflexion in an open chain. So this is where you've got to have really sort of confident clinical skills or clinical handling skills and assessment skills. If you're not particularly confident or you haven't got good control over the foot within your assessment, again, that's something that I can teach you guys, or you can jump in and do some assessment courses. The SFMA is a great one for that, Selective Functional Movement Assessment through FMS. That's where I learned a lot of this. If you don't have those skills, then you can absolutely just measure dorsiflexion in a closed chain. Are you going to be missing some pieces of the puzzle? Sure, but at the end of the day, you're at least getting a firm idea of what the foot can do in relation to the knee. All you need to do is just get yourself a clinometer. You can get one on your smartphone or you can purchase one, and you fix the clinometer to a fixed point. Again, I can run you through this in the garage or when I'm up in Ballarat as well. The goal is to fix the clinometer on a flat surface. So if we're doing dorsiflexion in a closed chain position, we'll be in a half kneeling position, and we're going to fix that clinometer on the flat bony surface of the shin just below the tibial tuberosity. And what we do is just translate forward into our ankle clearance test or our ankle measurement test, and we can use that to record how many degrees of clean dorsiflexion we get, and then we can measure that to the other side. We're looking for a minimum of 40. If you want to be able to squat with any modicum of depth and not have to be compensating through the foot, the knee, or the hip, or the lower back, 40 degrees is the minimum. There's a couple of papers that have been published that if you ask me very nicely, I will go and dig for them in my EndNote somewhere. But 40 degrees is the happy minimum. You can get away with less. I get away with less, but it's not recommended if you want to dive into the world of performance. Inversion and eversion are challenging because while they have an axis that they move on, that axis is actually rotation, and it's very hard to measure an axis of rotation without a fixed point. So what I like to suggest with inversion and eversion is, so you can sit yourself down in a seated position and then just try to lift the inside of your feet towards each other and then the outsides of your feet away from each other. This is inversion and eversion. And what we're trying to do is assess whether or not someone can do that in the presence of a tibia, a shin bone that stays vertical. This is our first introduction when we come to assessing movement patterns of moving parts versus non-moving parts. So this is an example where I can sit someone down and assess their ability to invert and evert. Without having to measure it, I can say comfortably, you're not meeting the criteria I need because I can see that you're struggling to keep your shins from getting involved in the process. So they either have an inability to access that inversion and eversion, it could be a mobility restriction, or they have a motor control deficit. If they have a motor control deficit, I can just challenge that with some dynamic or static stability through the foot or the lower quarter, these lower limb control zones. And if they have a mobility restriction, well, then I can either use my hands to create more range, or I can get creative as a coach if I don't have those manual handling skills. But I use my eyes for inversion and eversion. That's a visual assessment for me. And again, I'm watching the non-moving parts rather than the moving parts. Okay. We move into the knee complex. The knee complex, as force travels up through the ankle complex, it meets the first of several long... Oh, by the way, I'm sorry that my animations aren't working tonight. When I transferred it from my main computer to my laptop, my animations didn't carry over. I'm really annoyed because now it feels like a uni lecture and it really annoys me. I'm sorry. As force travels up through the ankle complex, it meets the first of several long bones that create a vertical line of force. Remember, force likes to travel in straight lines up towards our center of mass. So this moves through our tibia and our fibula. The first point where these vertical lines change direction dynamically is at the knee. So if I'm standing in a straight line, then the force is moving in a straight line from my foot all the way to my spine. If I'm moving, then the force is being translated differently based on how my knee, or the position that my knee is in when my foot touches the floor, and the knee that the position that my knee is in when it passes across where my midline is or my center of mass is. So we're talking about walking essentially. You can imagine my knee is in a different position. It's not in a typical extended position. When I reach out and touch my heel to the floor, there's a soft bit of flexion. And also my knee isn't in rigid extension as I move through my hip extension and my gait cycle. So the knee is a complex that is quite complex, and I really like it. And I hope you guys will too after this, these next couple of slides. So the knee is its own complex with its own intricate ways of navigating forces being delivered either up to the hips or back down to the ground. Remember, all force that we generate or produce from the ground must come back down to the ground as well. The most complex part about the knee, however, and my favorite, is that the function of the knee changes based on whether it is flexed or not, or whether it is flexed or extended. Note, it is difficult to discuss knee function without considering hip function. Did I just draw something on the thing? That's pretty cool. Okay, I don't know how I did that. It is difficult to discuss knee function without considering...
Sorry, that was me.
Oh.
I don't know what the hell I did.
Thanks, Lockie. Good job from you, mate.
No worries, mate. Hold on, I can get rid of it too.
Thanks, mate. Let's get the hell out of me. I was like, what the hell? Oh, that's cool. So it is difficult to discuss knee function without considering hip function. They are both so closely interlinked in terms of agonist and antagonist tissues and pattern synchronization that assessing one without the other is missing at least half the puzzle. The same goes for the joint below, the ankle complex as well. So the knee's quite a dumb joint, and you can actually play with this now. If you're sitting down, just kick your leg out straight. Your knee won't point wherever your foot doesn't. So you can't, in a straight leg, you can't point your knee unless you're pointing your foot and your hip there as well. So the knee is quite a dumb joint, but in that simplicity is actually quite a lot of complexity, because when we bend the knee, the rules change based on the length and tension of tissues around the knee and the hip. I like the knee a lot. I think it's a lot of fun. So in this position here, I'm going to move this over here actually, just so that I can be a little bit more... That's better. Now I don't have to keep doing this. So, beautiful. So we've got 3 different positions here. We've got a standing position, a seated position, and a standing position with the knee bent. So what we're looking at here is 3 different positions, but they're not different in terms of anatomy, because the anatomy doesn't change. We've still got the same amount of bones, same amount of muscle, same amount of tendon, same amount of ligaments. What we're changing are the positions relative to the ground and the hip. And that's very important to understand. We're not changing the anatomy. And this is a bugbear of mine. We're not changing the anatomy. We are changing the positions relative to the hip and the floor, the ground. So when we understand these different positions, we actually change the movement mechanics quite drastically. So in the first image here, we're in a standing hip and knee extended position. So if you can see here, where are we? There we go, the first position. So we're in this standing hip and knee extended position. And in this knee extended position, our anterior and our posterior thigh muscles work to lock the knee, so the tibia, on the femur or tibiofemoral joint, which is just here. We lock that in place from accessing further range. And this function is based on the congruency or the shape of the femur as it sits within the grooves on the tibial plateau. So this is the meniscus of the knee. It creates some grooves, and you'll see that in the next slide. So in this position, the nervous system is working to manage the center of mass over a very narrow base of support, which is obviously the feet. Because the feet are connected to the ground, and that's where we transfer force back down into. So we're producing force from the ground, and we're transferring it back down as well to create stability. And so the knee is extended relative to the ground rather than relative to the hip. And we're going to move on to this one, and maybe you'll start to see the pattern here. So in this second image here, we've changed the functional demands on the knee by changing the load demands of the knee relative to the hip. So here, our center of mass is, or center of gravity, where they're different, but is based over the midfoot. Here, it's based not over the seat, but based between the 2 points that we are fixed to. So it's based here. If I was to take my foot off the ground, it would be based here over the seat. I'm going to read that first line again. In the second image, we have changed the functional demands on the knee by changing the load demands on the knee relative to the hip. As a result, this has changed the congruency of the knee, which you'll see in the next slide, as we will see in the following slide. But the important thing to note here is the different changes in anterior and posterior tissue. So if we're in this hip flexed position, our anterior thigh tissues, have they shortened or have they lengthened? Throw me out an answer while I take a sip.
Lengthened.
Lengthened.
Same.
So we think that in this hip flexed position, our anterior, our quad muscles have lengthened.
Is rec fem lengthened or is that shortened?
Correct. So we're in a hip flexed position. Are we hip flexed relative to the ground or relative to the knee? And this is where the difference comes in, right? What about our posterior thigh muscles? Have they lengthened or have they shortened?
Shortened.
They're shortened, right? Because the posterior thigh muscles, the hamstrings, they help to flex the knee and extend the hip. Our anterior thigh muscles, our quad muscles, they help to flex the knee and, extend the knee and flex the hip. So in a seated position, our quad muscles have actually shortened because it's passive. We're not actively hip flexing. It's passive. However, there are going to be some constraints on that. I just want you guys to understand the difference that we're going to come into on this third one. Relative to the hip and the knee, we haven't really seen an extensive length change in either the anterior or the posterior because they're both passively moving the same distance. But if we're going to split hairs, they're kind of both shortening. Because you've got your origin and insertion on the front side moving closer together and your origin and insertion on the back side moving closer together. So in this second image, where we've changed the load demand on the knee relative to the hip, we've actually created shortened muscle through both. So we've changed the functional demands of the knee in a knee flexed position in a hip flexed position. which is why I friggin' love the knee. And then we go into image 3. So we're back in a standing position and we've again changed our knee position. But I'll ask you guys this. Have we changed our knee position relative to the ground or relative to the hip?
Relative to the hip.
What do you guys think? Relative to the hip or relative to the ground? Let me ask you this. Have the quads gotten shorter or longer?
Longer.
Yep. Have the hamstrings gotten shorter or longer?
Shorter.
So we have changed our knee angle relative to the hip. Here we've changed our knee angle relative to the ground. So it's just open and close change, just a different way of thinking about it. Oh, let's get that bad boy off. Does that make sense or no?
Yep.
Boys?
Yeah, man.
This is something that we can...
Yeah, for the most part.
It'll make more sense when you see what the ankle and knee complex do with each other. But in an open chain environment, we're changing knee position relative to the hip. In a closed chain environment, we're changing knee position relative to the ground. So in a knee extension position, there's still that red dot there. That's so good. In a knee, that's got me. In a knee extension position, as the knee sits in extension, anatomical locking of the tibia onto the femur takes place. This functional complex is known as the key lock and happens via a lower limb muscle called the popliteus. It works differently depending on whether this knee is flexed or extended, whether you're in an open or closed chain as well. In a knee extended position, the popliteus will work to laterally rotate the femur onto the tibia, securing the femur and tibia within the sagittal plane. This is another one where people like to split hairs, but I like to think of it as if you're locking your knee out, then you're screwing the femur, into the tibia rather than the tibia into the femur. And you'll see why. This process helps to create straight line tension. Again, force likes to move in straight lines, aiding in directional force or directing force from the ground straight into the pillar. But the nature of this lock makes the knee joint in this position particularly susceptible to sudden and violent changes in force direction, such as high external impact, like a tackle, or a plant or pivot, which is also known as cutting, as an individual changes their direction. So it's designed specifically to aid in creating straight line tension and force in a straight line. However, it works against the body when we are trying to move or navigate force in the other two planes. But that doesn't mean that the knee is a bad joint. It just means that we have to consider the way we think about it. So now my favorite, we can start to see this congruency of the knee. In a flexed position and in an open chain, the popliteus will work to medially rotate the tibia under the femur. So here is where you can put your foot on the ground and don't let your thigh bone move, and you'll be able to spin your foot on an axis. This is tibiofemoral rotation, and this is popliteus and biceps femoris with a little bit of semitendinosus as well, getting involved to create spin at the tibia, internally and externally. In a knee flexed position and in a closed chain, this is very important, especially for any powerlifters that might be watching. The tibia will not rotate because the foot will be secure on the floor. Instead, the tibia will work to create a stable platform for the femur to rotate on as the hip moves through flexion as well. So we're thinking about a squat. I'm going to reiterate this again. Open chain, you'll be able to spin your foot internally and externally. In a closed chain, you can't do that because your foot is fixed on the floor. But what you will be able to do is create rotation at your femur. You can't create much rotation at your femur when you're trying to open chain spin your tibiofemoral joint. It's important to understand here So I'll ask the question because we've got 5 minutes before I have to start a new recording. Thanks, Zoom. What are some implications that may arise from a tibia that does not medially rotate in an open chain? Will it allow for that open chain rotation, that upper chain rotation, so the femur, in a closed chain environment? Based on what we know about mobility, motor control, and dynamic static stability of joints within a sequence or pattern, what do you guys think will occur if I was to load this lower body flexion pattern, so a squat? What do you think I might see that will give away that this person may be missing open chain tibiofemoral rotation, internal rotation? What's something that you guys think I might see? Throw them out. There's one big giveaway. But there's
Something at the foot?
Huh?
Is that the foot or the hip? Is that the foot?
Tell me, man. You tell me. There'll be a lot of things that I might see, but there'll be one big one.
Is it like knees collapse, like inward?
That could be one. Yeah, I could see a big valgus movement.
Valgus, yeah.
The
I was
foot
thinking,
turning outwards.
yeah.
Say again.
Foot turning outwards.
100%. That's the big one. I'll see the foot spin. I'll see the foot spin out. And when the foot spins out, I sit there and go, oh, someone's missing some tibiofemoral internal rotation. When you cannot rotate against that tibia, you lose the ability to manage force, torque at the hip joint because you have nothing to externally rotate against. So you'll create your external rotation at the hip by spinning the foot out on the floor. Now, the problem with that, if you guys remember back to webinar 2, can anyone help me define flexibility and why flexibility at a joint is important? We have 3 minutes before it kicks us out and I have to restart this Zoom. So we're not in a rush. That wasn't sarcastic. We're not in a rush.
That shit's so simple, but can't remember.
It's simple when you start to see the pieces fall into place. So flexibility is contractility of tissue. So we are looking to
Muscle tissue.
see about the contractility, the 360 degrees of contractility around a joint. Because remember, joints move through 360 degrees. They don't move in 2D, they move in 3D. We see them move in 2D, but they move in 3D. So if I'm missing the ability to access external rotation based on the flexibility of my internal or external rotators, then I'm going to lose the ability to produce torque or successive induction. I'm going to lose the ability to navigate successive induction throughout a pattern. If I'm in end range external rotation because my external rotators are too tight, then they have contracted to their end range too early and they can no longer produce force to get me out of that position. Also, they can no longer create stability for my internal rotators. So what's going to happen is at the bottom of my squat, when I come out, my nervous system is going to go looking for length because length and tension dictates that a longer muscle is going to be able to produce more force. It's going to sit there and say, you've run out of contractility in external rotators and they help you extend the hip. So what I'm going to have to do is find a muscle that's nice and long to help me get out of this hole before I can get the glutes to help. Hey, adductors, you're going to help me. And I'm going to valgus as I drive out of the hole of my squat. Now that could be a flexibility issue at the hip, or it could be a lack of internal rotation at the tibia. There's so many factors. No answer is right. But if you have a more holistic approach to movement and how movement patterns work with each other and that no pieces work in isolation, you'll start to see that these problems like a spinning foot can easily be managed by thinking a little bit differently about the movement pattern itself. Does this person have enough length at their glutes to actually achieve end range hip flexion and maintain stability of the hip? Do they have enough length at their adductors that they're able to achieve external rotation? Do they have enough spin at their tibiofemoral joint? This is a very deep Alice in Wonderland approach to movement, but this is what gets me excited about movement patterns, particularly when I load them and particularly when I get to work with athletes that lift a lot of weight, because you can make big changes by changing very small things without the movement patterns or without the throughout their parts, and then helping them reintegrate those into their movement patterns, all based on understanding these little things. What happens to a knee joint in open and closed chain, knee flexion, knee extension? What happens to a hip joint in open and closed chain, hip flexion, hip extension? What happens to a knee joint in open and closed chain, hip extension and flexion, etc., etc. So we understand now that movement, it can't help but leave hints. It likes to be caught out misbehaving so that we can improve it. But when our egos get in the way, that becomes our biggest roadblock, is when, you know, we can see ways to help someone improve their squat and they aren't interested in it. And that's fine. You know, not everyone will be. We create spaces by making ourselves better movers, and the people that do want to work with us better movers. And then before you know it, people come and they want to get better. And that's cool. All right. So let's recap the knee. So I'm going to move this bad boy over again so we can see. All righty. So we've got the knee complex. So it's made up of two major bones, right? It's made up of the femur, which is here, and the tibia, which is here. And both have that relationship that's dependent on where the femur is relative to the ground and whether or not the foot is touching the ground. This relationship with the ankle complex means we can tie the two together and call them lower limb control zone 2, or LL2. And it is the furthest from the pillar. So we are looking at here to here. That is your lower limb control zone 2 right there. It's your knee complex and your ankle complex and how they synergize with each other. Essentially, I like to couple. So when I'm assessing lower limb 2 or LLC2. I will be referring to someone's ankle complex, their ability to dorsiflex, plantarflex, big toe extend, and tibiofemoral rotate. And when I can write those down on a piece of paper, I've just done lower limb 2, and I've got all the data I need, and that takes me less than a minute. And that's really powerful information that you can get. Remember, we don't measure inversion eversion, we watch inversion eversion. And then we measure dorsiflexion, plantarflexion, big toe extension, and internal external rotation of the tibiofemoral joint. Now, knee complex ranges. Flexion's a little challenging, and I'm going to tell you why. So flexion in a hip extended position, typically one fist. So it could be yours or it could be the client's, doesn't matter. One fist away from their heel to their butt. The reason this is so hard to measure is because thigh muscle or thigh bulk can inhibit somebody's ability to access knee flexion, but it doesn't make their ability to access a pattern bad, because the movement will occur with muscles rather than trying to move around muscles that are just bulky. The same thing with knee flexion in a hip flexed position, one fist from heel to butt. All we are trying to do with flexion is typically assess the quality of tissue across the knee and the hip. So we're looking at anterior tissue quality. However, with extension, we can measure 0 to 10 degrees in an open or a closed chain pattern. It's easier to do this in an open chain, but this one is good just for clearing any hypermobility. So we want to catch this early. And then tibial internal rotation is that seated, so this position here, and then we're just asking them to windshield wiper their foot inside and outside without the thigh moving, the femur moving, and without their toes lifting off the ground. I intend to have videos for all these, but as well, like I said, I'm going to be coming up to Ballarat on the first weekend of July, and then every couple of weekends. And I'll be in Frankston for anyone that's in Frankston, and I can run you guys through this anytime in the garage or when I'm up in Ballarat. It's important to see this and then understand how you can put this into your practice. And if you want a more in-depth look at this, I learned a lot of this from the selective functional movement assessment through FMS, which was a very powerful eye-opening experience for me in terms of making movement a little bit more nitpicky, which I like. Okay, so we recap here. We've got our lower limb, or LL2, lower limb control zone 2. Now, LL2 is important because it dictates function throughout the entire chain, literally the entryway for force entering through the body. Now, we got the 3 different images here. So we've got our standing, seated, and single leg. So we've got the different images, different positions, but the anatomy doesn't change. We still have the same bones, we still have the same muscles, same ligaments, same tendons. It's just movement mechanics have changed. They're in different positions relative to the foot or the ground, and the hip. And that's all we're trying to do, is just assess whether or not we are in an open chain or closed chain environment, and how we are implicating specific joints or specific control zones throughout that pattern. If you're in a deep end range of a squat and you haven't assessed tibiofemoral function, you could be missing easy gains that you've just wasted 8 weeks blasting yourself in a squat program over, when all you might needed to do was just unlock your popliteal muscle, and all of a sudden, hey, you've got more internal rotation to access hip external rotation. It's something, sometimes it's that easy, and people don't believe me until I show them. All right, we're moving into the hip. The hip isn't scary at all. In fact, the hip's super easy. So we move into the hip. If this picture looks familiar, this is essentially what I took from the pillar way back when. All you have to do is just blot out the pelvis, because the pelvic girdle only houses the femur, but the pelvic girdle actually doesn't do much moving. So when we talk about hip flexion, hip extension, abduction, adduction, external, internal rotation, circumduction, it happens from here. And it's very important to note that ball and socket joint, and also the way that the socket, so the hip socket, is facing towards us slightly. So if we were to take that ball out, we'd be able to see the shallow recess, or it's actually quite deep, but the recess face of the hip from the front. But if we were to go around to the back of the hip and pop the joint out, we wouldn't be able to see the face, the inside face of the hip from the back. So the hip socket is slightly facing forward. It's on a 30 degree from lateral, slightly anterior facing direction. Very important to understand for the next couple of slides. So our leg bones here are what we're going to be focusing on. They're our big movers and shakers when it comes to lower body power and control of force. And they're often overlooked because this whole complex gets a little bit misrepresented. Okay. So let's look at hip flexion, abduction, and external rotation. I've coupled them together. The femur is a ball and socket joint. This fact hints to its function in more ways than we know on the surface. I'm going to stop and I'm going to really quickly tell you why this is important to consider. We see the world in 2 dimensions, even though we know it's a 3-dimensional world. I have a sphere here, and it doesn't matter which way I spin it, you'll only ever see a circle, okay? When we look at movement, we're seeing movement in a 2-dimensional pattern, but the movement is happening in 3 dimensions. So our nervous system interprets our own movement as a 3-dimensional movement puzzle. But when we coach, we have a tendency to get locked down in 2-dimensional thinking. When we look in an anatomy book, we see flexion happens in a straight line, abduction happens in a straight line, external rotation happens in this line. It all happens together. It's all coupled. And that is part of 3D movement. And it's very important to understand this principle, because we can't get bogged down in 2D thinking. Otherwise, this principle or this lesson won't land at all. So we have to think outside the box here. We see in 2D, but we move in 3D. So we have to start thinking in 3D, particularly when we coach. So we know ball and socket. From this front side diagonal view, so we've slightly tilted the pelvis. From this front side diagonal view, we can see that as the femur moves forward into flexion, so I've flexed my femur, I've lifted my knee, the ball within the pelvis is also externally rotating. Let's take it back. Bang. There's the top of the femur. Bang. Now the top of the femur is facing this way. Let's go back. It's facing straight up. Now it's facing out, because the hip is externally rotating as the femur flexes. Flexion and external rotation are coupled. You don't see it because you only see movement in 2D. And we are a big skin suit filled with sticks and pudding. You aren't going to be able to see what's happening at the hip. Just understand that the way that it's designed is that when it flexes, it's also externally rotating. This comes back to our principle on flexibility. If you don't have flexibility around the hip and you try to flex your hip and you run out of flexibility at your external or internal rotation, that's going to create some problems. Okay. As it does this, the femur moves away from the midline relative to the fixed foot and tibia below. Thus, the femur is also abducting away from the midline. So if we were to take it back in a straight line, as we externally rotate the femur, if I want to keep moving in flexion, I have to move this femur away from my midline. So this knee, while it is in front of me, will start to travel away from my other knee to create an open hip position relative to a fixed foot and tibia. If I'm missing internal rotation at the tibia, I will spin the foot, as Michelle rightly pointed out. In an open chain, we can manage the direction of force by maintaining the femur's translation to the midline. This is an important to understand as well, meaning we can move the femur forward without the lateral drift into abduction. So if you were to stand on one leg and lift your leg and keep it in a straight line, you can mitigate the abduction, but you are still flexing and you are still externally rotating within the socket. This is particularly important for straight line force production like sprinting, where we are trying to minimize the deviation away from straight line force production as much as possible, because force loves straight lines. If we are externally rotating and abducting when we sprint, then we're going to have to pull that leg back into the midline to create extension. And that's wasted energy. That's force bleed, which we talked about in last week's webinar on the pillar. That's force bleed. When we are deviating away from straight line force, that's force bleed. In a closed chain, however, a squat or a split squat, this method is just not feasible. Due to the fixed nature of the foot and the tibia, the femur does not have the room to move purely in a straight line going forward. So that's what we just talked about, right? Fixed foot, fixed tibia, it has to have something to rotate on, otherwise the foot rotates out. When we have rotation through the lower control zone, lower limb 2, then the femur now has something to externally rotate and abduct against when we move through our hip flexion moment. And so we'll couple the external rotation occurring at the hip socket with abduction of the femur away from the midline, creating our rotation relative to the fixed tibia, relative to the ankle complex, relative to the floor, where we produce power or force. This rotation cannot occur if the tibiofemoral joint is lacking the reciprocal internal rotation in an open chain that we can assess really easily. Michelle picked it. Good job, Michelle. This slide is super easy. It's the opposite. The hip is so easy. Hip extension, adduction, and internal rotation. The exact opposite is true for our femur as it moves into extension. The shape of the forward-facing socket creates a natural internal rotation of the femur as it moves its way into hip extension. I'm going to pause it there. Let's go back. So we look at this hip. Remember that it's forward-facing. As my hip moves into extension, it is now going to rotate the other way. And as it does, the front side of my femur will start to twist in. So I will be internally rotating and I will be drifting towards the midline. I will be adducting. Hip extension, adduction, and internal rotation are coupled. You need them, particularly if you want to run fast or lift heavy. As a result, in order for our body to maintain center of mass over the foot within the frontal plane, because let's go back, frontal plane now, we need to be able to maintain the midline in the frontal plane because we're on one leg, not in the sagittal plane. The femur must adduct towards the midline, or rather, if the femur is fixed in a closed chain position, when would the femur be fixed in a closed chain position in an extended, adducted, and internally rotated position? Someone throw it at me.
You say again, sorry?
Yep. When would the femur be fixed in a closed chain position when we are in an extended, adducted, and internal rotated position?
Closed chain.
Let's take this position, tilt it forwards 45 degrees. So when we are
Like a hinge.
when we're running,
Oh, like, yeah, back.
This hip will be in a closed chain hip extension, adduction, and internal rotation moment. If you're missing anything, if you're missing extension, if you're missing adduction, if you're missing internal rotation, there'll be compensation that occurs at the pelvis, or at the knee, or at the ankle complex. And that will create, on the opposite side, force bleed, because you'll have to create a force to stabilize against the lack of stability you have here. Plus, you'll have to create a force to drive your next step into the ground. Just changing the way we think about movement. So if the femur is fixed in a closed chain position, the femur will propel our center of mass forward and maintain a midline position with our other leg throughout the gait cycle. We'll go over that one more time. As a result, in order for our body to maintain a center of mass over the foot within the frontal plane, the femur must adduct towards the midline. So if we are standing in a single leg position, we will shift our weight via our femur so that our midline moves closer to our femur. We are adducting the hip so that we can stay over the foot in the frontal plane. But when we are running, we aren't adducting our body, because then we'd be doing this. Instead, we are using reciprocal extension and internal rotation and moments of adduction to create a straight line midline position, because force likes moving in straight lines, I'm told. Now, as was true with webinar 2, when you are missing the crucial pieces of mobility within the puzzle, that is movement patterns, it's certainly not the end of the world. But if you want to unlock free, ready to be accessed force production for people looking to squeeze more juice out of the performance fruit, it's hard to spot a deficit and walk past it. And this is why I'm picky. And you can choose not to be picky and still do really well as a coach or a therapist, but I am super picky, because if I'm picky about movement when it doesn't matter, I'm not going to miss it when it does matter. I'm going to say that again. If I'm picky about movement when it doesn't matter, I'm never going to miss a deficit when it absolutely does matter. And I don't care if you're the best in the world or the worst. If I come along and pick a movement deficit, when you tell me that this is the best athlete in the world, and I pick a movement deficit that's really easy to fix, it may or may not make them better. But if it's something that we can chuck in a program that only adds 5% yield, but doesn't take anything away, if it's something as simple as, let's just spend an extra 5 minutes across an hour working on some hip extension drills. If you can't tell me with a straight face that it's not worth doing that, and it's just worth lifting them or running them or putting them through plyos, then I would argue that your program isn't worth the paper it's written on. Because if you're picky about movement, when it doesn't matter, you will catch it when it does. And it's the moments that you catch it when someone comes to you and they have chronic hip pain and they're worried about going in for surgery because they've been told they've got a femoroacetabular impingement, which is an impingement in here, in your femoroacetabular joint. And a surgeon loves to go in there and clean that out. And then you never have the same range there again. When you're a 23-year-old female footballer and you come to me and say, I've been and seen 3 physios and a sports surgeon, they want to cut me open. And then me, a lowly diploma of remedial massage and cert 3 and 4 personal training, comes along and says, you don't have an FAI because I just proved you don't have an FAI. You have a pelvic instability where you are stuck in anterior pelvic tilt and you're running into the front of your pelvis. You could develop into one, but we can work out of that. And I take your chronic pain away in less than 10 minutes because my assessments are pretty strong. I take your pain away and then we get you moving really well. And you go back and you play for Box Hill Hawthorn. I still won't mention her name. And then she wins a grand final. I get a say in this stuff. When you are picky about movement, when it doesn't matter, you will pick it up when it does. And you may save a girl who's 23 years old from a surgeon's knife when she doesn't need the surgery. And then she can go on and do the things that she loves doing, playing sport, and be a contributing factor to winning a grand final for a football team. That's why being picky with movement is important. Understanding these principles when it comes to movement is also very important. Let's go over the hip complex. Let me move this bad boy over here. So we've got the hip and knee complexes that they work together, and they make up lower limb control zone 1, or LLC1, or you can just say LL1 if you want, lower limb 1. So a lack of mobility or control through this region can have consequences on function above and below. As this complex is that last stop before the pillar, bang, there's the pillar. It's right there. That's stage 1 of the pillar, piece 1 from the ground up, pelvic girdle. As this complex is the last stop before the pillar, it's a great investment within a program to ensure ranges of motion are known, measured, and managed throughout a program. Let's go through them. Hip complex ranges. Flexion with a single leg. We're looking for 70 degrees minimum. So that's an active straight leg raise, 70 degrees minimum before non-moving parts start moving. So if you want to pause this video, if you're watching it after the fact, or if you guys want to stop after this video and jump on the floor, you can measure this, lay on the floor, be honest with yourself, lift one leg, stop moving that leg when either your torso wants to get involved in a flexion moment or when your other leg wants to get involved by lifting off the ground. Because as soon as a non-moving part starts moving, bang, you're out of range. It's really easy to measure. Single leg, active straight leg raise, 70 degrees. This isn't measuring the ability of the mobility of flexion in that leg. This is measuring your ability to flex a leg against a hip that remains in extension. So the leg that stays on the floor, has it got enough extension to allow you to express single leg flexion to 70 degrees? If it doesn't, we've got something that we can work on. Free gains. Bilateral flexion, we need 120 degrees. Extension, 0 to 10. There's a specific assessment that I use and I learned from my mentor and colleague, Greg Day. It's also in the SFMA. It's called a Faber test. And again, I'm going to show you guys this stuff when we catch up in Ballarat and Frankston. This is a 2-for-1 test because it assesses hip health, and it's what I used to assess this person's FAI. This test takes a hip and moves it into flexion, abduction, and external rotation, and it crosses the foot over onto the opposite knee. And then you just drop this thigh, this femur, out into external rotation abduction. And what that does is it puts stress on the front of this capsule here. And when someone has an FAI, a true FAI, they're actually running the neck of their femur, this bad boy here. They're running the neck of their femur, bang, into the rim, the lip of their pelvis. They're not hitting bone, they're hitting cartilage. So they're hitting the lip, which holds the head of this femur in. And they're chewing it up. So there's a test that allows you to test, not only does this person have the ability to get into extension at 0 degrees, but do they have a healthy hip? This person came to me with pain in her hip. She presented with a positive finding with a Faber's test, but then when I allowed her to apply stability through her upper body, so I allowed her to align her pillar by just asking her to, she was laying on a table and her arms were above her chest and she just pushed down against my hands. So I just said, don't let me push you, pushed against her hands. That resulted in her anterior chain accepting load, and it realigned her pelvis, her spine, her ribs, and her shoulder girdle. So it realigned her pillar and it took her pain away. So that proved that she didn't have a medical problem and they were going to go in and cut her open. I'm glad I did the test. She didn't have hip extension though. And that was where we started. Gave her some hip extension, took her pain away. 10 minutes. Best $90 she ever spent. External rotation. In a hip flex position, so supine, you can get 30 to 40 degrees minimum. If you don't have it, you should get it because it's going to affect your ability. If we're in hip flexion, it's going to affect your ability to access external rotation and abduction. Better believe it will. External rotation in a hip extended position, you'll be prone. So you'll be on your tummy, 40 degrees minimum. There'll be variations. Internal rotation, hip flexion, supine, so on your back, 30 to 40 degrees. This is also a provocative test for people with hip pain or hip impingement. And then internal rotation, hip extension, prone, so on their tummy, 30 to 40 degrees minimum. Again, there'll be variation. There are congenital or orthopedic conditions that occur at the hip, as is conditions that occur at the spine, the shoulder, the foot. So if you're wanting to get clinically minded, then there are things that you can become aware of. And if not, then you can always refer out if you're unsure. Now, here's a note. I haven't mentioned anything about adduction or abduction in terms of measuring those ranges. It's as true with the ankle as it is with the knee and the hip. So there'll be places that require higher levels of of a coach or a clinician's coordination to measure. Like inversion, eversion has an axis of rotation that's just too hard. Thoracic spine can be quite challenging. Lumbar spine can be quite challenging to measure rotation or lateral flexion. So if these are areas that you want to upskill in, by all means, go for it. But before you do go and upskill in them, start to learn these ranges really, really well. Get your hands on a clinometer or download a clinometer on your phone. Learn to measure these ranges and get really familiar with LL1 and LL2 so that when you go and learn these more complex assessments, you've got a great foundation of hand-eye coordination and body control when it comes to the more complex assessments. I'd argue that adduction and abduction are absolutely important to consider, but they're also coupled with hip flexion and extension and external and internal rotation. If we take it back, if I don't measure your abduction, but I do measure your hip flexion and external rotation, and I find both your flexion is fine and your external rotation is fine and your hip extension is fine, but you can't access this pattern, well, then I've just nailed it that you probably don't have abduction. So it's just ruling stuff out trial by fire, like just trial and error. So let's go and explore why you don't have abduction. Now I can do some passive work. If I have to go back and take those steps, that's fine. But that'd be such a rare occurrence because they're also coupled together. And again, there's tests that are built in to this system, like this Faber test that I'm going to show you guys, where it asks you to show me if you've got available abduction because I want to see if you can get into extension. So I'm going to pick up abduction in that test anyway. And if you don't have abduction, I'm not going to expect you to have adduction either because of the principle of flexibility in terms of length and tension of tissues at a hip joint. So if we're lacking in a hip joint in one range, remember 3 dimensions, then we're probably going to be either lacking or we're going to be compensating on the other side of that hip somewhere. So it's just trying to change the way we think about movement. If we find a problem, if it smells like a dog, it's probably a dog. If we find a problem, we fix it. We see what it does to the movement patterns. Same for external rotation and internal rotation. These are quite easy to measure once you get the feel of it and the hang of it. And you can do this on yourself. You can do this on partners. You can do it on your clients. Don't just measure it if you just want to measure it for the sake of it, because sometimes clients want to see what the point of measuring it was. Measure it if you're interested in changing it. And if you're interested in changing it, come up with interesting ways to determine whether or not it's a joint or whether or not it's a tissue. Again, there are courses that you can do that will help you navigate those hurdles, those obstacles, but these are just ways for you to change the way that you think about movement. This is LL1, I beg your pardon, lower limb control zone 1, closer to the spine. So we're understanding, we're just understanding the natural couplings that occur at these joints. When you understand these natural couplings, and they occur everywhere, when you understand it, you'll start to see that big toe extension plays a role in hip extension through gait cycle. Big toe extension also plays a role through the opposing side when you're trying to run and you've got to use both legs to do it. If you can't extend your hip on one side, you'll be anteriorly tilting your pelvis, which will close the front side of your pelvis down, and you will lose the ability to flex the other side because you'll run out of range. So big toe extension might be the thing that's holding someone back from expressing all of their power when they sprint. And yet they've got to go and do strength training because the strength coach tells them that they've got to improve their lower body power. And then big dumb Cam Elliott comes along and says, this person has no big toe extension on one side. They've got a bunion or they've got an ingrown toenail and you've got them squatting. Has anyone thought to consider this health problem that this person might have? Just different ways to think about it. Let's get this out of the way. Get that bloody bugger out of the way. All right, so this is essentially the lower limb slides. The upper limb slides, again, as I said, I've had to cut this in 2 pieces as well because of the recap, but the next one won't take half as long, which is good. But here's what I'll leave you with the lower limb. So we understand these couples and stuff, but just understand that if you don't have the positions, it doesn't mean we stop squatting or deadlifting. It doesn't mean we stop running. What it means is that we've got a handbrake on, but you can still drive the car. Just understand that you've got a handbrake on. So we want to work to build programs to help remove handbrakes and manage movement better in the gym so that we can do it on the field. We can do it in the sport that we want to do or the hobbies that we want to do. If you can't do it in an open chain, don't expect to be able to do it in a closed chain when it comes to movement patterns. Let's flip it on its head. If you can't do it in an enclosed environment like the gym, don't expect to be able to transfer it into an open environment like the field. That's just lazy. If we sit there and just say he got stronger because he's lifting more weight, he must be a better footballer now, that's just lazy. If you can't do it in an open chain, don't expect to be able to do it in a closed. If you can't do it in a closed environment, don't expect to be able to do it in an open environment. That's just how it works. If you can't load it in the weight room, how on earth do you expect it to carry over to the field? Like, will they get stronger? Yes. Objectively, they'll get stronger. But if you're happy arguing the point over a half-assed adaptation, then again, I feel like we're not being picky enough about movement. And, you know, it comes down to whether or not you want to split the hairs. I like splitting the hairs because I like to be picky. And I like building really movement-rich programs. And I also like lifting heavy. I like getting sweaty. I like building aerobic energy systems and anaerobic energy systems. But if you can't move in a position, you're working harder than you need to. That's crazy talk.